Hi, I'm Stephanie Shelton, and this is episode 40 of Conversations on Health, How We Get There. Donald Trump has changed America in many ways since his second term began a year ago, but perhaps in none so personally important as our overall health and health care. On February 25, 2025, the Senate confirmed Robert F. Kennedy Jr. as Secretary of Health and Human Services. Nearly a year later, he has managed to dismantle or redirect much of it. Among the multitude of public health agencies administered by HHS, the one where we've seen perhaps the biggest changes is the Centers for Disease Control and Prevention, or as we usually call it, the CDC. Many experienced scientists and other employees have resigned or been let go. Many research grants to universities or nonprofits canceled or cut back. And many long-term health policies have been changed. RFK Jr. has tried to promote a long-debunked link between childhood vaccines and autism, and between Tylenol during pregnancy and autism. This last was definitively shot down this month by a retrospective study in the prestigious women's health journal Lancet. A meta-analysis of 60 studies found no association between Tylenol, when taken as recommended, and autism, as well as no association with intellectual disability or ADHD. Now, the other big area attacked by RFK Jr. and his appointees has been vaccines. For both adults and children, routine recommendations have been removed from the CDC website, and the members of the Advisory Committee on Immunization fired and replaced with RFK Jr.'s choices, including a number of vaccine skeptics. Perhaps the most controversial change, posted in early January, is the Childhood Vaccine Recommendation Schedule, reducing the number of routine vaccines from 17 diseases to just 11. After much discussion, measles did remain on the list, as a measles outbreak raged in South Carolina, doubling in just a week and spreading to at least 3 other states. The outbreak mostly among, you guessed it, unvaccinated kids. In late August, a group of CDC senior officials and scientists resigned after CDC Director Dr. Susan Monarez was fired. She refused to implement RFK Jr.'s vaccine policy changes, and among those who walked away from their long-term CDC careers is my guest on this episode, Dr. Daniel Jernigan. Dr. Jernigan is a nationally recognized public health leader with more than 30 years at the CDC, where he directed the National Center for Emerging and Zoonotic Infectious Diseases and the Influenza Division. He's led responses to major health crises, including anthrax, SARS, H1N1, Ebola, MERS, and COVID-19. And he's authored over 160 scientific publications. He's a medical doctor and has a master's in public health. Our conversation clarifies a lot of now murky health issues. So, here we go. Dan, thank you so much for coming on the podcast. This is a real privilege to really talk to someone who was there when it happened, as it were.
Great to be here. Thanks.
So, let's go. You and a whole group of scientists and directors and leaders of the CDC resigned in August, and other people had resigned before, and additional people have resigned since. What is the status of the CDC now as you see it? And obviously, you're not exactly unbiased, but where does it stand? What has happened to an organization that was like the preeminent health organization, I think, in the world?
No, you're right. I think historically it was a global leader. It was the trend setter for public health globally. And so that's really at risk right now. There's a lot that's happening. The thing that's important is there's still a lot of people there that are extremely smart, extremely gifted, very mission oriented. Those are people that are still there doing the regular work of public health. I think where we're seeing things really come apart is around that vaccine issue, about the vaccine safety, about the vaccine schedules, things like that. So there are things that CDC does that are still in place and still very trustable. But there are some things now that I'm having a hard time understanding what's the right thing to believe for what's coming out of some of the information about vaccines at CDC.
I think that childhood schedule that posted very recently, in the midst of a growing measles outbreak in South Carolina, where most of the kids weren't vaccinated. And there's a whooping cough outbreak now. Whoever heard of that? I mean, I'm old enough to remember before all these kid vaccinations, and a lot of diseases we lived in real fear of. It's hard to believe that anybody would want that kind of a world to come back again. I mean, be like places in Africa that have never had access to vaccines.
Right. So you can see that's happening right now. The schedule change that you alluded to was a very bizarre way of having policy for the United States around vaccines. Historically, we have a system in place whereby a consideration for a vaccine is made. There's a group that reviews that, the Advisory Committee for Immunization Practices. They go through a process called the evidence to recommendation process, whereby they look at the science, they grade the science, how good is the science, and then with that, they make decisions based on risk and benefit. What's going to be the best thing for this child, for the population, and to decrease overall impact from side effects. None of that happened with this most recent change. We ended up with a document that came from two individuals that are working out of the secretary's office that was more of an opinion piece than a scientific based document for making decisions. And so that document then was given to the secretary and others and to the director of CDC to make a recommendation to change a whole lot of vaccines that children currently get without any discussion with the public, without any discussion with the pediatricians groups like the American Academy of Pediatrics. Those kinds of decisions historically take time because they're big decisions. They have big impacts in terms of cost. And it's not something that just gets made on the fly with an opinion piece from a couple of people.
It seems to me that the most difficult thing to figure out, aside from the fact that I think it was six vaccines that were just completely dropped, and of the remaining ones, some of them say there's shared decision making about it. Well, truthfully, does anybody take their kid to the pediatrician and say, okay, doc, whatever you say? Not today, not in today's world. You're going to ask questions. Isn't that already shared decision making? So, what are they even talking about?
I think it's a good point is that parents have always had the ability to say, I don't want this for my child, to talk to their doctor. And there are exemptions that are out there. All states have them, et cetera. So it's not that people were being forced to do this, but there was this sense that if you can move things from fully recommended to shared clinical decision making, that you would somehow be introducing more choice for the parent or more engagement with them. The concept of shared clinical decision making has really been used in the past for those kinds of vaccines that are actually of uncertain benefit for some people. So, for instance, if you are over a certain age, we don't currently recommend Mpox. But if you, let's say, have just recently divorced, you're going to become much more sexually active as an adult. Well, in that situation, it may make sense that you should take an Mpox vaccine. So that's where shared clinical decision making comes in, where the actual data is kind of on the fence, but the context of that patient may make you make one decision one way or another. It's not meant to be a way to say you need to talk to your doctor more often. And so I think by putting in that shared clinical decision making, it introduces a kind of uncertainty. It puts vaccines that have been recommended with all the evidence for a child to take them, it puts them into a category of think about it. And I think that's a real shame. It's a real shame because a lot of people, do have a pediatrician. There are a lot of people, though, that are resource challenged that really don't have a regular physician.
Yes.
They have to go to an emergency department. And the concept that you should opt in to get some of these vaccines when you really have no way to opt in because you don't have a provider.
Yeah.
It's not fair to those children to have them figure all this out, find a doctor in order to get something that was previously recommended for all of them.
And what happens? It's quite normal. I live in New Jersey, a really crowded state. Most of us don't go to a doctor for vaccinations, and I see parents, with their kids getting the vaccinations at the pharmacies, the CVS's and the Walgreens of the world. What happens to that kind of ease? Because you can just walk in and say, I want this shot. If you have to have, if there's a specific proviso in that schedule that says shared decision making.
Yeah, I think by expanding broadly the use of shared clinical decision making, it does call into question who's allowed to be that provider of clinical of guidance.
Yeah.
Is that a pharmacist? Is it a doctor? Is it a nurse practitioner? So I think the decision to make that, overall sweeping recommendation by the secretary and his staff really didn't take into account the implementation of things. And again, going back to the process that's supposed to be used for big important vaccine decisions, that evidence to recommendations framework, implementation of vaccines is a critical component of making that decision. You weigh the risks and balances, you look at costs, you look at implementation. How easy is it to do what we're requesting? And I don't think any of that was considered as they were making that recommendation.
And I think when it comes to rural areas where it's so hard to get medical attention anyhow, even for people who are willing to drive 50 miles to see a physician, but they might have a CVS in their main street or their little town, it's going to make it impossible. And that is just a crime to my way of thinking
Yeah,
anyhow.
I think if the goal is to help people prevent these diseases, this doesn't help. If the goal is to prevent people from getting to those vaccines, then this is helping to achieve that agenda.
How did we get to this point? I know about Maha. I remember in my gym we had a young mom who kept saying, there are too many vaccines for my kid, my little kid. Shouldn't I be able to make that decision to put them off for a while? She was college educated, had a high job in New York, and she thought she knew more than the doctor. And I guess it's a legitimate question that you would discuss with your doctor. As you said, if a parent really has doubts about this, and of course, if the kid has issues of any kind, health issues, most doctors would say, yeah, we can pull it out a little longer or wait a little longer. So I know how it started. What I don't know is how it ended here. Uh, it and I go back when I asked that question to COVID and to when the vaccine became available and how wonderful it was to, I would say, almost all of us. I mean, I don't know anybody who was walking around saying, I want to get COVID. I live and work, I live close to New York. I've worked in New York. I saw the bodies piling up outside the hospitals. I mean, that was not something that you wanted to avoid, something that was life-giving like that vaccine. So how did we get from that moment? And you were a lead on that. So of all people, you know how much of a miracle it was that it got developed that quickly. How do we get from a miracle to, I don't think the vaccines, any of them are safe.
So I think one important thing is it's a lot of the views that people have are perfectly valid, to ask questions about what's in a vaccine, to ask questions about whether their children should get them. Those are things that parents should be asking. So that's not where we're going here. I think if you go back before COVID, there really were two kinds of sides of things. There were those that were very concerned about what was in the vaccines, about their children getting too many vaccines on kind of one side of the aisle.
Mm.
On the other were those that were really not wanting to have government intervention, to have any government involvement in their lives. With COVID, I think there was the opportunity for those to come together. Masking, vaccinations, the requirement for people to get vaccinated before they go to work, things like that.
Mm.
All of those, I think, coalesced that group, and that group became much more supported by Secretary Kennedy and a lot of those that had been in that space previously. So these are views that people have, but if you look at how people accept vaccines, even still, most people are perfectly fine getting their children vaccinated with measles, getting them vaccinated against polio and other things.
And
So,
measles remained after all the drama about the vaccine. Measles remained on the schedule.
oh, absolutely, and that's because it is a highly contagious vaccine virus, and so you want to make sure that you're preventing that. So, those two things have come together, and I think the secretary and the president really have given the platform to normalize that, or to really take an ideology which may have been used to help guide some tactics as you go into a new administration. That ideology is now deep within the agencies and really looking not only to direct what the agencies are doing, but in fact to go back to the originating data, reanalyze it, and come up with alternatives that have been agreed to for many, many years. So that's a very big change that has happened with this current administration.
Um, the last thing I will say on this vaccine schedule is that the model for it was Denmark. And I've done a lot of podcasts on healthcare systems in other countries, and at least one Scandinavian country. And the bottom line is they have universal health care. They have taxpayer provided, government regulated health care. Everybody has health care. No matter who you are, the smallest person, you can walk into a doctor's office and get what you need, or into a hospital and not worry about it. In our country, I would say 50% of people do not have adequate access to health care. And you would know this better than I. It might be even more than that. But if you don't have it through, an insurance um, provision through your work, and of course, right now, with the subsidies taken away, a lot of people who are using Obamacare, small businesses, for their workers can't do it anymore. The workers can't afford it. The businesses can't afford it. So again, you can't. And the other thing, which a number of people have pointed out, is that Denmark is a homogeneous country for one reason or another. It's the size of one of our states, and everybody is pretty much similar. They don't have a lot of immigration. We're all different. We all come from different backgrounds with different types of genes and all the rest of it. So I don't quite understand how they went to Denmark for that schedule.
So it's an interesting point. In Denmark, even if you talk to other European countries, I think they would call Denmark more of an outlier
Yeah.
than the United States. So the total number of vaccines that they're using, I believe, is this lowest of the European countries, or what they're calling the peer nations. And so it's an unusual thing to, if you read through the assessment that was provided to support the changes that were made, it's unusual to see evidence-based decision making as a driver. That is, we use scientific evidence, and in the same sentence they say, and we use the practices of peer nations, which I'm not familiar with any past policy, any health policy really, that says we're going to use the science and then we're going to use what other countries are doing. Historically, the United States has been a leader in public health.
Exactly.
They are the ones that set the stage. If you look at the trajectory of a lot of those countries, they're moving toward more vaccinations. These countries have to make decisions because they provide all of the health care. They pay for all of it. It's like you mentioned, universal health care. And therefore, they are going to take their time to make a decision, especially about a new expensive vaccine.
Mm.
In the United States, We basically have made those decisions. We want that protection. They are going to be costly, but we will cover them with the Vaccines for Children program for those that can't cover it. And insurance companies will pay for the rest. So it's an odd thing to use Denmark as the benchmark because it is, in my estimation, it is the outlier, and it is like you mentioned, extremely homogeneous. The population is very similar. They're all very close to healthcare because it's a small nation, and all their healthcare is provided. All the parents, excuse me, all the women that are pregnant are getting prenatal screening. So things that we don't have here are routine there. And to say that we should then switch to this lower vaccination model, even though other peer nations don't, it doesn't make sense to me.
I think that's it. It doesn't make sense. And I think it doesn't make sense to a lot of us who look beyond, our immediate family, perhaps, and look at the world the way it is. I mean, what happens? I think of this ramp up for COVID, and remember that was under Trump. I mean, that was one of his great achievements to get that vaccine out. Um, what happens the next time? Because probably it's not going to be 100 years this time. We weren't flying around, in the old days like we are now and going back and forth from all kinds of countries. So it's likely to be sooner rather than later. Would that be a fair statement? And then what?
Yeah, it's a great point, and I think we can maybe even look at this year's influenza season. So we've got lots of flu happening, and it's happening all at once. And it's in particular because of what's called antigenic drift. That means that the flu virus that's out there causing disease has changed. It's called subclade K, and it's just causing loss of disease because it is evolved past our own immunity and past our past vaccination efforts. If we were to have something like that, that was a really different, shifted kind of virus that would cause a pandemic, I personally believe that we're in a situation that's worse now than we were even before COVID. And so, why is that? A couple things. One is that the administration has separated from the World Health Organization, so we don't have the ability to monitor what's happening. We're not as closely connected in with the monitoring of those flu viruses or viruses that may appear, COVID 27 or whatever the next one is. Um, we also see that there's this diminishing of vaccine coverage and of vaccine distribution. So for flu, if you look at how many vaccines have been ordered, they're definitely down. And then if you look at how many people are getting vaccinated, that's also down. So we have fewer people that are wanting it. And in part, that's because I think we have an administration that's basically telling them, maybe you don't want this.
Yeah.
And so the third thing that's probably the most problematic for being prepared for the next big thing is there's this dismissing of the mRNA vaccine. So that
Yes.
thing, like you mentioned, that the COVID vaccine that was stood up so quickly was manufactured very quickly. Safety testing done, effectiveness studies done, all through Operation Warp Speed, which is a potentially Nobel Prize winning activity for
Yes.
the president. Um, that has been dismissed. And in fact, they've not only said, we don't want that vaccine, we have concerns about it, but they have stopped getting the funding for the pipeline. So I think not only have they made us less capable right now because of surveillance and the diminishing in vaccine demand, we're also less capable because of the technologies that won't be there, the mRNA vaccines. Other countries are probably going to have them. China will have it, but the United States may not.
And didn't they dismiss all uh, the exploration that was going on with the mRNA as a base for not just vaccines, for cancer, for all kinds of things they were working on?
Yeah, there was about a $500 million amount that was pulled away from the mRNA flu and other vaccine work. I think mostly infectious disease work that was placed elsewhere. And so that to me, again, it's really keeping the pipeline from being there for whatever the next big thing is.
Well, that's encouraging. Um, the one thing you don't want in your healthcare is chaos. Uh, and I just have that sense. Um, and I have that sense when I need figures. Um, it's been pointed out that the average physician, if they get someone in as a patient who has a specific disease, they will look on the CDC and look for best practices and what's new and what's being worked on, and and they will trust the information there. And I get a sense that that might not be a great idea anymore because you don't know what is being meddled with and what is actually the truth.
Yeah, I think it's a question that gets asked a lot is, what can we trust on the CDC website? I do think that a lot of the my concerns are mostly around that vaccine safety and the vaccine recommendation space. I have yet to see significant changes to other things like foodborne diseases or others where the information that's there, which has much of it has not changed, is very stable, very important information that's very helpful for state and local health departments and for people trying to make decisions about infectious diseases and other events that are affecting them. But for the vaccine part, I do think that that's a concern. Your your concept or your statement about chaos, I think, if you look at what the secretary has been doing, it's kind of a playbook. Some of this you can look at from before he became secretary in his book called Vax Unvax,
Mm.
where he walks through and basically says they're going to do everything that they are doing right now. And that is, change the Hep B dose, get rid of the COVID vaccine, get rid of the flu routine recommendation, et cetera, get rid of pregnancy vaccinations. His most recent members that he put onto the brand new ACIP are both obstetrician gynecologists, both of whom have past history of being very vaccine hesitant. So if you were to look at sort of the playbook, there's kind of a set of things. The first that he's really doing right now is ramping up regulations. And so you can see that right now, if you're a manufacturer of vaccines, the work you have to do now in order to get a vaccine approved just got a lot harder. And in fact, for influenza vaccines, there's some possibility that they won't be able to just change the component like they do every year as the virus is changing like it did this year, but we'll have to do new trials each time that they make a change to it. So that ramping up of regulations is going to be a real problem. Another thing that they're doing is increasing injury claims. So there's a thing called the Vaccine Injury Compensation Program that there's liability protections for manufacturers of vaccines so that we can get innovations, we can
Hmm.
get lower cost vaccines, and we can get vaccines that are able to cover the less common diseases, and the market is not so big. By saying that the harms that can be associated with vaccines can expand, maybe autism, maybe allergies. And by removing those liability protections, which is something that Aaron Siri, who is a lawyer that works with Senator Kennedy, Secretary Kennedy, they're basically saying that we are going to remove that liability protection. So
Mm.
that injury part is just a second kind of piece of that playbook. Let's get rid of let's make the regulations harder. Let's make it easier for those injuries to become something that people are liable for, either doctors or the manufacturers themselves. The other is the pipeline, like we talked about, the mRNA vaccines. They're trying to get rid of, they're bottlenecking all that new technology that might be coming through by making it unfunded or difficult to do. And the one thing I think that's really concerning for me is they're raising the risks of vaccines and they're burying the benefits. So
Yes.
basically saying that, you know, the, a there's a possibility of autism. So they changed the CDC website so that they're now raising the risk of something that was not considered a risk previously. They're in the ACIP meeting where they bring up uh, a mouse study that showed some allergies from one of the vaccine components. Is that evidence at the same level as all these other evidence? But they're raising those risks so that it makes it much harder, uh, so that all those risks are sort of at the same level. And parents are seeing all this risk, but then we're hearing them say, well, the benefits of the vaccine have been over, spoken. That you don't really have those benefits. So raising the risks, lowering the benefits, but then what that ends up doing, to your point, that's how we got here, by the way, is the casting of confusion. So
Yeah.
basically, it makes the parents say, okay, well, do I have to figure all this out myself? Do I have to read everything and then go into my doctor and have an informed conversation when in fact part of the doctor's job and part of public health's job is helping the public understand what the right thing or the best thing to do is so that they're not all trying to figure it out themselves.
Yeah, exactly.
We don't ask people to go and replace their lawyer. We don't say, hey, you go to court and you be the lawyer. We People take on the role of a person that is an expert and a recommender. So that casting confusion, all of those things are really leading to driving down the confidence in vaccines. We're seeing less people take vaccines, and we're definitely seeing less people order vaccines as well.
Which means if you do have an emergency of any kind, I mean, let's just say this measles situation does get out of hand and it's back again the way it was when I was a kid. Um, and you need vaccine fast. You're not going to have a manufacturer because they don't make that much money on vaccines to begin with, right? I mean,
Right.
it's not like, it's some brand new miracle drug that they can charge anything they want for. Um, so that manufacturer is just not going to be there. Maybe the manufacturers will be in other countries, and other countries will have their hands on the amount of vaccine that's being made already, and there won't be any for us. I mean, there are all kinds of scenarios I can envision, all
Yeah,
of them bad.
I think yeah, Paul Offit was talking about that just yesterday. That he's recalling back into the 1980s before there were liability protections, and the numbers of vaccine manufacturers had dropped down to four because it was just not tenable for them to do it. By having some of those protections in place, it does allow for innovation, allows for less common vaccines to be available to people because costs are a little easier to manage. And it does make it possible for more people to get those vaccines as well.
Right. Well, so far we're not looking at a great trajectory for the future. Um, what about this is somewhat off the realm of vaccines, but not of the illnesses that they're supposed to keep us away from the worst effects of, anyhow. What about the relationship between the state health departments and the CDC? They've always cooperated with each other, state departments, and as I understood it, because this came up from a question of can we trust any of the figures coming out of any agency now, not just the CDC, on anything, unemployment, whatever. And it was explained that all of these figures come in from the state departments and they come in such a way as they really can't be manipulated. So then I thought about that, and um, I read that CDC is no longer requiring states to give them flu figures any longer in their state. So you actually don't know what the flu situation is in numbers in people, except if a state decides to publish its own on its own. You're not getting a picture for the country.
Yeah, I think the um, the connection between the state, territorial, local, and tribal health departments and CDC is a very long-standing one, and the support for all of those activities really comes through CDC. If you look at communicable diseases groups at state health departments, about 90% of their total support is coming from CDC or federal funds. So I think a lot of people don't realize how much their own state health department is actually dependent on the resources. Equally, the work of trying to come up with recommendations, work through the evidence and provide that in a way that's translatable, that's been a CDC activity historically. And if states are no longer able to, or if they feel that they are no longer able to trust some of that information, then they have to do that on their own. And that's not an easy thing to do. There's not a lot of staff to do that. And the expertise to do it is not available everywhere. You can see right now some alternatives that are developing. There's a West Coast consortium that has stood up, that is a group of states that are essentially coming up with their own recommendations and approaches to public health implementation that are separate from what CDC historically would do. Same thing happening in the East, Eastern Coast states. There are then groups also in the Midwest through University of Minnesota, where they've developed the Vaccine Integrity Project, which is a group who takes it on the hard work of looking through all of the studies in anticipation of an ACIP, vaccine recommendation. And so if the CDC is not able to do recommendations, and to be honest, with the most recent schedule change, there was no ACIP in that. So maybe you don't need the ACIP anymore. But if there are going to be recommendations made, there needs to be evidence evaluated. And so what I'm seeing happen is the Vaccine Integrity Project that has Rochelle Walensky. It's got a number of folks that are working on that activity. They are providing the evidence review, and then the recommendations are being made by the American Academy of Pediatrics and by the American College of Obstetrician and Gynecologists. So I think we're moving to a place where the CDC and the ACIP are being decoupled from those recommendations. A lot of states, mostly blue states actually, had written into their own their regulations that the recommendations for vaccine would be tied to the ACIP.
And I think we should define what is the ACIP for people.
Sorry. Yeah, the ACIP is the Advisory Committee on Immunization Practices. And so it's a group that is following congressional language on how they are supposed to be constructed, what processes they use, and what kind of recommendations they make. So advisory committees, there are many of them across the federal government. This is the one that is set up to advise the director of the CDC on vaccine recommendations. It's not the group that makes the recommendations. It makes recommendations about what the recommendations should be. And so it says to the director, here's the data, here's what we think are the right things to do. And then the director of CDC makes that decision. And so right now we don't have a permanent director of CDC. We have an acting director, right, that person. So that ACIP is supposed to follow Federal Advisory Committee Act rules, which a lot of people say they have not been following. And personally, I feel the same way. So that committee isn't doing what it's supposed to. It's had people put on it in a way that is not consistent with the way you're supposed to put people on it. And it's made recommendations that are not following an evidence to recommendations framework. And therefore, AAP, ACOG, and many states are saying we cannot follow this set of recommendations anymore.
So what you're getting, in a sense, is almost a shadow CDC. It's not one organization, but if you want the facts, there's a place to go. And that in itself is going to create a problem, because there are people who say, well, if my government says it, it must be true. And there are other people now who are saying, but we have a group of the scientists who make the recommendations, and have been making them over here. And these are the people we should believe. And then they're going to be the people in the middle who just say, I'm not going to do
Yeah.
anything. Like you said, I'm not capable of making that decision for myself. Who should
Or
I believe?
yeah, and so it's again that casting of confusion that really leads to inaction, which is the outcome that I think a lot of them are wanting. A lot of this is about shared clinical decision making. They use the term informed consent. All of this it really boils down to talk to your doctor about it.
Mm.
Well, if you look at what the doctors are saying right now, which are those represented through AAP, the American College of Physicians, through the American College of Obstetrician and Gynecologists, through the family physicians groups, through all of those, they're basically saying we cannot do what the secretary is saying because we do not see that those recommendations were made based on scientific evidence.
Right.
And so if the response is to talk to your doctor, right now those groups representing doctors are saying this is not something that we can stand behind.
I think I think that this whole idea of science is somehow, and I think this is part of it, and it's not specific to the what's happened at the CDC. I think people don't understand science. You kind of expect things to stay the same. If a scientific paper comes out, I mean, I'm thinking back to food, and I'm thinking back to coffee, and I drink a lot of it. And we've gone through coffee is bad for you, coffee is good for you. Coffee is more than good for you. You actually, need the caffeine. It can do great things. And you don't know where it's, so you just say, I'm just going to drink my coffee.
Yeah.
Obviously, vaccines are a lot more important than that. And there are other things like that. But the whole point of science is it's living. And as we discover new things, as we, think about it, we didn't have television at one time. We didn't have radio at one time. That's science. It's technology, but it's science. So as new information comes available and people learn how to work with it, things are going to change. And they may change for the better, they change for the worse, but it's science.
Yeah.
And I think people don't understand it and have difficulty accepting that, particularly when it comes to medicine.
Yeah, there's a couple things there. One is just the advisory committee we talked about. It's an easy way to make people's eyes glaze over.
Yeah.
And so it's policy, it's translation of science, it's processes. It's just not either that interesting for the most part for most Americans, or it is just complicated and seems trivial. The reality is that things that are being recommended have impact on 300 million Americans. They have the potential to greatly increase the costs for clinicians who have to do additional visits.
Yeah.
It may lead to people not getting vaccinated and having illnesses like meningitis. Somehow that's now not a recommended thing. And well, it'd be only for people with risk groups. Well, any kid that goes to college is at risk,
Yeah.
and you do not want a child to lose a limb or to die from something that, a year before they were getting vaccinated for. So all of those things it is complicated. But yes, the science can be a little hard to follow. But, it is on us to try and translate that as best we can for the American public so that they can make those decisions. For me, the issue is not so much what is it that they're saying about the science, that I believe the science says this. To me, the science is always changing, just like you said. It is a very dynamic landscape. The more you look, the more you find that things change, and you have to change the recommendations with that. So it's not so much what the science is saying, it's the process you use to evaluate that science. And that is a single laboratory experiment that might show some allergy is interesting, but that does not rise to the level of importance. It's not proportionate to the need to change an entire vaccine schedule. So that proportionality, that risk and benefit that has to be considered, that's the hard part of public health.
Mm.
That's what the secretary and his staff are just simply not doing. It's their job to try and do that thing, not just to raise the risks. So, so with the science, it's really the process. How are you evaluating it? Not so much what are the findings that are coming out right now.
So, just to kind of wrap this up, I mean, we could go into other areas, but this is the area I think that's most concerning. What, looking forward now, um, and without, some huge happening like another pandemic or something, what is the outlook for America's health? And if we are not a healthy nation, what is the outlook for us being allowed to travel, for example? Does a vaccinated country want an unvaccinated country, coming in? Um, think of the diseases people can bring back and forth. So where do we go from here? I mean, what are we looking at as a country?
It's hard to say because some of the recommendations that just came out did not affect the reimbursement for those vaccines. And so it's a strange situation where we have a set of
I'm just
recommendations.
cutting in on you because what we need to say is that the insurance companies have said, along with Medicare and Medicaid, that they are going to pay for whatever
Yeah,
vaccines were on the schedule as of last September, which is all of them.
yeah. Yeah, so I do think that you see a growing wave of societies, of doctors, of others that are really saying, this is too much. We've had too much. This is enough. And so I think what would be great to see is a group of parents that are basically taking on the role of you know, you are affecting my livelihood. You're affecting what my kid might get when they go to college. You're affecting my kid from having to have problems where, other kids at school have diseases that my kids should not be exposed to. So I think if there could be a more concerted effort among parents, and certainly what we're seeing now with the coalescing of a lot of activities that are becoming alternatives to the regular process for getting vaccine recommendations. That I think will be helpful. We'll be in a different place than we are now. That still has to be defined, but I can see people are really moving in that direction because people want to have good public health that protects them and it does the most that it can to prevent those kinds of illnesses and deaths that would come if we were not vaccinating.
Well, it's good to end on a somewhat hopeful note. Is there anything else that you would want to add to this discussion that we didn't go over?
I do think that it's important that people communicate, that you communicate to your local congressmen, your local representatives, because the decisions about vaccination and what happens at a school with vaccinations, that's all really a local thing that happens.
Right,
And
right.
so it's important that people that respect this kind of recommendations and want these kinds of things for their children actually need to be vocal at that local level. And so it's important, with Senator Cassidy and others at that level. But the real change can really happen if folks do take that effort to reach out to their local representatives and tell them how important it is for vaccines to be available for their children to prevent deaths and hospitalizations.
Okay, Dan, thank you very much. And I really appreciate your spelling it out for us because your clarity helps a great deal.
Well, thank you. That's very nice.
Dr. Daniel Jernigan is a nationally recognized public health leader with more than 30 years at the CDC, where he directed the National Center for Emerging and Zoonotic Infectious Diseases and the Influenza Division. He's led responses to major health crises, including anthrax, SARS, H1N1, Ebola, MERS, and COVID-19. And he's authored over 160 scientific publications. He's a medical doctor and has a master's in public health. There's a lot more, which I'll add to the show notes. There's so much to talk about right now when it comes to our health here in the U.S. I'm not sure which of the next two episodes will feature what or whom. We have two exceptional guests lined up. Another former CDC leader, Dr. Karen Hacker, will be discussing chronic disease prevention, the unit she headed before leaving the CDC. Karen has an unusually wide background, including teenage health, and is currently an adjunct professor at the Rollins School of Public Health at Emory University. My other guest, Stephanie Hodges, is a registered dietitian with master's degrees in food policy, applied nutrition, and public health. Her organization, Nourished Principles, does public health consulting. Stephanie will be analyzing and explaining RFK Jr.'s new and controversial, what else, USDA food guidelines, the so-called inverted food pyramid. This one. You've seen it, right? Upside down with all the run-on pictographs. One thing you can be sure of, episode 41 will drop on the third Tuesday of February. Since, as you know, I schedule one new podcast episode a month. Check the show notes on my website for whether Dr. Karen Hacker or Stephanie Hodges will be on the February pod. And as always, please subscribe and share. The video versions on YouTube, audio on Apple, and all the other major platforms, including my host platform, the Podbeam website and app. Show notes and links on my website, stephanieshelton.com/conversations. I'm Stephanie Shelton. Take care of yourself and all those you love, and I'll see you around the next time. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.